how they actually, at the cellular level, it affect the airway lumens and the airway wall. So all these pluripotent rhetoric of inflammatory mediators will be secreted, and depending on what type of allergen or what type of exposure that the patient is exposed to, then they will activate that inflammatory pathway that can be basically more towards the eosinophilic or allergic pathway, or the other one would be more towards the neutrophilic pathway. And all this will actually can cause airway remodeling by actually contract the smooth muscle, and it can cause bronchoconstriction. So basically, as what we're going to learn about allergy, the phenotype of asthma can be from allergic, eosinophilic asthma, and also neutrophilic asthma. It's quite complicated, and as I said earlier, it is very heterogeneous. So we know that the pathogenesis not just involve the immune hyperresponsiveness, but also it will actually activate the global cell hyperplasia. This will cause the mucus hypersecretion. That's why when the patient actually cough, they feel that there's something, there's a thick phlegm, but unable to expectorate. This is how they feel. And with this mucus hypersecretion, especially if let's say they actually block the airway, and you know our airway, we have different calibers. So different generation of airway. So we have 23 generation of airway. So the distal part, the distal airway will be smaller, less than 2 micrometer. So imagine if there is a lot of mucus hypersecretion being produced, so it will cause a blockage, obstruction, and it will cause air trapping. So that's where the patient will experience chest tightness, and later on will produce the sound of wheezing that you listen, patient can actually listen to it. And when you auscultated the lung, you actually listen to the rhonchi. So this is how it actually occur. And patient in any individual, so we could actually overcome the hyperresponsiveness with our innate adaptive immune system. However, there are certain stage whereby this inflammatory mediator will be overproduced, and later on there will be an airway remodeling will actually process sets in, and that's where a lot of fibrogenic mediator will comes in and cause the fix or it cause the smooth muscle to be actually become stiff because of the fibroblast. So therefore, there will be no more reversibility if at one point when the patient actually perform a spirometry. Then you don't be surprised that if let's say the patient perform a spirometry, you cannot observe the reversibility, especially for patient that has a long-standing asthma, and long-standing asthma specifically with a suboptimal medication. So this is the different phenotype of asthma. So as I mentioned earlier, it is a heterogeneous disease. So we always actually encounter type 2 asthma, which is more inflammatory, presence of eosinophilia, and you actually found in at early age onset. Commonly, they will have a childhood asthma, and later, when they enter adolescent or early adult age, the asthma become quiescent. Then later on, they will actually have the asthma, but maybe after 30 years of age and above. And you will see the patient will also have plus minus atopy or some IgE component as a clinical manifestation, and they're quite very responsive to medication that can treat the inflammation. The anti-inflammatory, to be precise, is the corticosteroid. And there are also entity of patients, maybe not as many as the one that you actually seen in your day-to-day clinic, patient that presented with asthma, usually type 2, but you also see non-TH or non-type 2 asthma, which is some can be less severe, some can be even severe. They can mimic like COPD because they are pro-neutrophilics, and some of them actually associated with smoking. They are also associated with obesity, and some of it we can't really understand the pathophysiology be underneath it, but they actually presented with the polygranulocyte disease. So you can't really find a high eosinophil count, high IgE, and even if you do the blowing test called fractional exhalation nitric oxide, you can't even see a high FeNO to demonstrate an airway inflammation. And also commonly seen in a late onset adult age, and usually will be among the ladies. So asthma is a very heterogeneous disease. So if you see a 10 asthmatic patient, they will behave not the same because it's very in intensity and vary over time and has a variable expiratory airflow. That's why if you do a spirometry, don't be surprised. The patient can actually exhibit a normal spirometry at certain point of time. If let's say they are more symptomatic, then you may observe the obstructive ventilatory defect, and also with reversibility if you do the post-bronchodilator. So if you look at this, the peak flow of a patient that being untreated of asthma, so you see the peak flow rate is very low. Then after get treatment, even on treatment, the it continues, the reading improve, but there is a slightly difference between the morning and evening. This is just to illustrate, to demonstrate that there is a vary over time and intensity of the asthma, even though they are already on treatment. So this is how you differentiate based on the clinical history from COPD patient. So COPD patient, chronic obstructive pulmonary disease, they have throughout day. They don't have the very over time, very of intensity. So always listen to your patient and always ask the correct questions. So typically, variable respiratory symptom being emphasized over and over again in the guidelines. So worse always at night. You see when you do your GINA assessment or your asthma control test, they always ask the symptom whether is it night symptom or day symptom. So always worse at night, and it can cause nighttime awakening. It may actually trigger by something that cause them to stress, exercise or laughters or exposed to allergen or anything that change the weather. Sometimes cold air is the most common, but we do found also some proportion of patients do actually be very sensitive to change of the weathers, even not just the cold, but also the hot weather. And symptom may worsen after end of exercise, but this is very distinctive and often appear or worsen with viral infection. So if you listen to your patient carefully, they always say that their symptom is always occur right after they have the URTI symptom. So their URTI symptom is always like every 4 to 5 times a year. It get better, but it will take longer time to recover. So these are some clues that it might actually encounter the patient has asthma just based on the clinical history. So the next thing is confirm with a variable expiratory airflow. So as mentioned earlier, so if you want to do a spirometry, you need to have a demonstrated a reversibility, which by definition is an increment of a FEV1 of forced vital capacity of more than 12% and 200 mils. So they need to fulfill these both criteria in order to say there is a positive post-bronchodilator reversibility. If this is not demonstrated, if the symptom from the clinical history, there is a variable of the symptom intensity and time, and the spirometry does not show reverse, the patient maybe do not smoke and some allergen atopy manifestation, you still can actually treat the patient as per asthma because it goes by the clinical history that presented with a variable respiratory symptom. That is the strong point. So sometimes this spirometry is just to tell us, number one, if you have a low FEV1 less than 60%, this is a high-risk patient that you have to actually treat all out. So you might not actually go slow with the treatment or with the inhaled corticosteroid plus long-acting bronchodilator. You might actually need to upgrade it to even medium dose of ICS LABA. So, and another thing is to look at the response of the treatment. So these are the things that the spirometry do not just serve as a for diagnosis purpose, but also as per monitoring and for prognostic as well. So besides spirometry, patient can also do a another spirometry after 4 weeks of inhaled corticosteroid treatment. But however, in our day-to-day basis, especially in government hospital, we can't afford to actually review back the patient after 4 weeks. But in a private setting, perhaps this is something that we can do, and we can actually see the increment of the FEV1 after 4 weeks of inhaled corticosteroid containing treatment. So you want to see whether there is a demonstrated 12% and 200 mils after the post bronchodilator. In some patients, they may not have a variable respiratory symptom. Therefore, you can't actually get the spirometry. So the history is really 50-50, but you still started on treatment. But still, the patient does not get better. So there's something wrong with the diagnosis. So maybe you could actually subject the patient for bronchoprovocation test to induce the bronchoconstriction. So the assessment of asthma control consists of a recent one. So a recent one means that you have a 4 weeks assessment, daytime, nighttime, whether the patient use a short-acting bronchodilator or any activity limitation due to asthma. So well-controlled consider they actually say no to all of the four components. If let's say one or two of these out of four, they are considered partly controlled. If they have 3 out of 4 of this, all the symptoms, then it's considered poorly controlled. So this symptom control is much important whenever you want to decide whether this patient need to be step up or step down the treatment, because we do not want the patient has to continue the same treatment. So you may want to adjust according to the patient suitability. Secondly, is the risk factor for poor asthma outcome. So we want to predict whether this patient is the one who you are going to anticipate going to end up in your high dependency unit, whether it's going to be intubated, or whether you're going to see them monthly in your ward because of exacerbation. Who are these patients? So those who are actually has a poorly controlled asthma, so maybe they are scored partly or uncontrolled, and they actually over reliance to short acting bronchodilator. They may not get a adequate dose of inhaled corticosteroid. They have other medical condition with comorbidities like obesity, chronic rhinosinusitis, GERD, which is not being treated well, exposures like they smoke or they even vape. So these are the things that we need to actually advise our patient to stop all these bad habits. And certain patients, they do actually have a major psychological or problem when they are actually having a lot of symptom. It causes more anxious and they get depressed because they can't go to work. They have to take long MCs and whatnot. And for school, for those who are actually going for college, it's going to be troublesome for them because they need to actually extend their semesters, for instance, because they can't actually cope with their severe, the high burden symptom of asthma, and also the heavy burden from the studies as well. So for patient who manifest a high marker of type 2. So what are the type 2 inflammatory markers? You look at the full blood count, look at the absolute count of your blood eosinophils. Anything above 150 cells or more than 100, 300 is considered raised, and high fraction exhalation nitric oxide. So these are the biomarker that we actually give us clue to the type 2 inflammatory markers. So any exacerbation history, so this is a mandatory history that we have to ask our patient. So if let's say for medical students or for master student get this asthma case for long case for the exam, so this is considered whether you actually going to pass with flying colors or you're going to actually fail miserably if let's say your history is not complete. So the risk factor for developing persistent airflow limitations. So there are patients, the sounds like asthma, but spirometry behave like COPD, meaning that they have a fixed airflow limitation. They do not actually demonstrated the reversibility. So who are these patients? So the patient may actually was a preterm baby previously, maybe 30 years ago. Maybe they are a low birth weight baby, and the medication perhaps under optimized throughout the diagnosis of asthma, and they smoke, and perhaps they already have a FEV1 low to begin with because maybe previous severe childhood infection. So the lung growing is not as normal as it's supposed to be. And another risk factor that we look at, don't forget, during the follow-up, which we always kind of miss it, is the medication side effects, especially for patient that came to you with a weight of 5 kilo after 3 months. So what happened? Why 5 kilo? Why out of sudden increased appetite? So ask them over and over again the prednisolone because this is, can be bought over the counter and you don't need a prescription. So all these actually some clues, then also from your clinical observation whether they actually develop Cushing. So you can tell then if they have all these signs, so you know that the asthma is not controlled, although the asthma control test is good. So besides doing GINA, you can use ACT score. So anything score 19 and below considered poorly controlled. So you need to actually adjust the treatment. Before adjust the treatment, always ask your patient whether they are using the treatment, whether they adhere to the medication, whether they use the inhaler correctly or not. So usually I will ask, I will actually focus on question number 4. If the rest are actually they score very well, either they score 4 or 5, and that will come out about perhaps a score of 16. Let's say they actually score 5. So 5 times 4 questions is already 20. They just need to have another one to say that this is a good controls asthma. And always you go look at the question number 4. If let's say they score 1 and 2, you know they are SABA reliance patients. So why they do not have none of the time they have the problem at school, they don't have shortness of breath, they don't have nighttime wheezing, early morning awakening, and the asthma control is considered completely good, is because of they use a lot of SABA. So this is another clue to tell us that the asthma control is not good. So don't just rely on the numbers, go by the individual's questions. Then you know whether your patient is actually poorly controlled or good control. And the asthma control status need to be actually determined by the symptom, nighttime awakening, the short-acting bronchodilator used for symptom control, any interference with normal activity, and they actually incorporated with the lung function. So this can be actually divided into intermittent and persistent. So if they have a persistent poorly controlled asthma, so basically we want to know whether this is mild, moderate, and severe to tell us the severity to actually allow us to upgrade the treatment. So if you do not actually have this information, you will just, a doctor will going to practice a CTS, continue the same. These are the 5R principles. So we move on to the treatment. So to achieve good asthma control, always with 5R. So you got a right patient means that you get a correct phenotype to match with your right drug, right dose, right route and technique, and right time. Why right route and technique is not just inhaler. We also actually use biologics, which is administered as a subcutaneous. So you see, one size fits all. It doesn't work this way. So a lot of inhalers, does it actually fits to all our asthmatic patients? So the question is no. So we go few of the case scenarios based on the phenotype. So the first phenotype that I'm going to actually discuss is the one that you actually encounter is the allergic asthma. So this is a young patient diagnosed with bronchial asthma with a past medical history of childhood asthma in the past, has a comorbidities, allergic rhinitis and reflux, history of intubation in 2021. So before admission of that intubation episode, so she was only on short-acting bronchodilator whenever needed. So this is where she bought over the counter. She actually do not actually use inhaled corticosteroid. So there was no regular follow-up for her daytime, nighttime symptoms 4 days a week until she perceived this is considered normal to her. So she has a zero tolerance to attack, and this is very, very dangerous. So she actually manifests as a type 2 asthma. So she has a high eosinophils, high IgE, and she has high exposures to the house dust mite. And her BMI is quite optimal. So maybe she does not actually use the short burst or the corticosteroid that much. But if you look at the spirometry, so it is demonstrated. So this is a considered normal spirometry, but based on this numerically. But however, if you look at the graph, this is a clear cut and obstructive ventilatory defect in view of the shape of the graph. So this is increased concavity. And if you see that this blue color is pre-bronchodilator, red color is post-bronchodilator. So there is a gap. If let's say there is no increment or no change after post-bronchodilator, the graph should fall on top of each other. So if there is a gap, you know that there is some reverse, but it does not actually meet the criteria numerically of 12% and 200 mils. So you know that this airway is not a totally fixed airway. There are some form of reversibility. So maybe she's taking oral corticosteroid before she's doing this spirometry, or she took 2 hours ago her bronchodilator. So that may actually cause the suboptimal spirometry results. So you can't actually demonstrate the true picture of obstructive ventilatory defect. The second one is adult onset asthma, which we always found in a patient that never had asthma before, but they had these symptoms suggestive of asthma during adulthood. So they are non-smoker. She used to work as a cleaner. So daytime and nighttime symptoms about the same 4 days a week, but she does not actually manifest any type 2 inflammation. So her BMI is just slightly on the overweight side, about 24. So when we look at the two profile of patient, so the first patient especially, she used a lot of SABA. So since 2022, the GINA already mandates time to move away from SABA monotherapy in asthma management. It's a big sin just to actually prescribe patient with a blue inhaler. There's no such thing of patient just use one inhaler which contains short-acting bronchodilator. And in fact, patient with mild asthma, even though they are just mild asthma, as I said, asthma patient, you can't actually just take things for granted or just a pinch of salt, or they are just mild asthma, but they are also at risk. About almost 40%, they can actually present it with acute asthma, near fatal asthma, about close to 20%, and almost 30% adult dying of asthma based on the assessment of they previously has been labeled as a mild asthma. So always careful when you encounter my asthma, never prescribe SABA PRN. That's a big no-no. Always give a inhaled corticosteroid containing treatment. If let's say the patient is very well, ACT is 25 over 25, for instance, and using religiously their ICS LABA regularly, so you can actually step down to 50% and they go by one puff daily up to the point that they go down to step 1 or 2, so they go by PRN basis, but there must be a content of ICS plus a short-acting bronchodilator or combination of fixed dose inhaler which contain of ICS with long-acting bronchodilator. We will go to the stepwise treatment later. So the impact of regular SABA use. SABA is good for faster relief, but it will not sustain. So if overuse it, so what happened? It causes a beta receptor regulation reduce. There will be no less bronchodilator response later if let's say this is being using over and over again. So it will actually has a positive feedback to cause airway hyperresponsiveness. It increase the eosinophilic airway inflammation. So therefore, the regular use of SABA without any inhaled corticosteroid is considered not acceptable at this present moment. So now, let's say you have a patient, you do not trust them. You can actually just Google Asthma Malaysia. So you can take this liver reliant test. So you can test them few questionnaires and what the score is. If let's say they score 25, this is the highest mark. So you know that this patient is a high risk over reliance on your liver inhaler. Sometimes the patient that I said, the typical will answer you, oh no, I did not use, very fast response, and you know there's something wrong with this patient. So you just test them on this and see whether they score high or they score low. So previously 1980s, so if anybody still practice SABA as a using as a monotherapy, you are in 1980s, 1960s. So you are not Gen Z, Gen X. So now we are actually targeting the inflammation. So we give anti-inflammatory. Any anti-inflammatory can be form of inhaled corticosteroid or the biologic that very targeted to the certain targets according to the phenotype of the asthma. So you learn about the asthma heterogeneous. So you have a time that the patient has a very high burden of symptom at certain point of time. So that's where you actually use your ICS containing treatment together with the bronchodilator at the point that when the patient has symptoms. So the window of opportunity when the patient has symptoms, so the inflammation will be actually increased. So you take the opportunity to give this combination that contain inhaled corticosteroid. So the corticosteroid will treat the inflammation. The bronchodilator will dilate the bronchus. So therefore, the patient get two effects at one go. So it's like throwing one stone, killing two birds. So the patient get a bronchodilator effect, and at the same time they treat the inflammation. Therefore, there will be double bronchodilator effect after the inflammation being treated. So this is according to the latest GINA 2025, the stepwise asthma treatment. So they actually divided into track 1 and track 2. Why they don't just do track 1? Because they want to, because this is a international guideline. So we have to accommodate to certain countries with less access to inhaler treatment. So there are countries that perhaps can't afford to give a two-in-one inhaler, meaning that they have a fixed combination of inhaled corticosteroid formoterol. So that can, if let's say for track 1, these are the one that you prescribe two-in-one inhaler, meaning that you have both controller and reliever in one device. In track 2, you have both. Two inhalers, mean that one inhaler is for controller, another one inhaler for reliever. But you do not use it that reliever whenever needed. You will use both together. So whenever there is a symptom, then the patient will use the inhaled corticosteroid together with the short-acting bronchodilator. So usually for patients that very non-compliant, SABA reliance, we prefer them to be on track 1 because we want to simplify the treatment. We want them to forget about the short-acting bronchodilator. We give a treatment that has two medication in one inhaler, simple, and especially for ladies, they don't need a big handbag to accommodate two inhalers. So for patients that use this fixed dose combination ICS, the LABA must be formoterol. It is not actually being studied for salmeterol or other long-acting bronchodilators. So formoterol, it seems that because it's F, is fast. So it works well, it works fast like your short-acting bronchodilator, but it's sustained because it's a long-acting bronchodilator group. So the patient will have a more time before they get the second dose of inhaled corticosteroid with formoterol. For patient that has started at step 1 or 2, so perhaps this patient in the primary care, maybe very mild asthma, so you just use as a air only, means that it is a anti-inflammatory reliever. So they use, whenever they need to use the SABA, they use the ICS at the same time. So if it's a two-in-one inhaler, so they use the same inhaler to treat as whenever needed. If it's once it goes to step 3, so they can use this as a maintenance plus MAT. MAT means that this is a maintenance and reliever treatment at the same time. So you can use extra dose besides the regular dose. The allowed dose is 12 puff a day. For any inhaler that contain ICS and formoterol. For track 2, 1+1 inhaler. So this patient need to be a very good patient that really listen to you. For non-compliant, you go for track 1. For very, very good compliant patient, you go for track 2. So usually doctors, teachers, track 1. Besides that, good patient, track 2. So we give 1+1. So you know that this patient will follow whatever you say. So they will prescribe with SABA and also inhale corticosteroid. And then you go by the step 2 and 3 and 4 and 5, depending on the back to your asthma control test or your GINA assessment. So whether this patient has a well control, partly control, or good control. So that will determine the step up or step down of treatment. So the key changes as mentioned earlier, so track one, the two in one, and track two is one plus one treatment. So how do you want to know whether this patient actually has low or medium and high? So remember, the low is actually at step 3. Step 4 is medium dose of inhaled corticosteroid, and high is actually at the step 5 treatment. So you have to know the dose of each inhaled corticosteroid. So this is just pertaining to the inhaled corticosteroid dose. The formoterol dose will be changed if, let's say, the patient use whenever needed. So the dosing of the step 3, 4, and 5, depending on the control of the symptom of the patient and also the choice of the inhaled corticosteroid. So is there any difference between the inhaled corticosteroid that we're looking at? So they are. So it depends on the receptor binding. So if let's say you're dealing with beclomethasone dipropionate, they have a very low receptor binding affinity, very lipophilic, very low volume distribution, very short time elimination, intermediate systemic potency. And this beclomethasone also, the particle is extra fine. And usually we love beclomethasone for patient that has manifest a small airway disease in polycontrol asthma. So these will be the best option of inhaled corticosteroid. The next is budesonide. So budesonide has a short dissolution time, very fast. It's very hydrophilic, so faster absorption into lung tissue and prolong the anti-inflammatory effect. That's why if you use budesonide plus formoterol, so you can use as a mud because of the formoterol. And also the budesonide is something like really fast, has a faster absorption component. So this is the one that you want, and it has a prolonged anti-inflammatory effect through esterification. So so every single ICS has their own uniqueness. For fluticasone, very high receptor binding affinity, so lipophilic, high volume distribution, and higher systemic potency because when it binds, it will actually stays longer. So usually we encounter lots of patients will develop pneumonia, especially for those who on a high potency of a inhaled corticosteroid. So this is some guide how to go about with the track 1 or 2 and depending on the symptom control of the patient. So this guide you on what to start, which track would you think the patient will be best on depending on your evaluation. So as mentioned earlier, you can step up, you can also step down. And the step down is always after 3 months. Don't go less than that. So always make sure that the patient do not have first are not in the high risk patient that you will anticipate this patient going to have a future exacerbation. So sometimes you can actually prolong up to 6 months and only you want to consider to step down the asthma treatment. So how much of stepping down is always by 50% of the initial dose. So the treatment decision nowadays in GINA 2025, they emphasize on the preferred medication at population level, meaning that this is at country level. So the access, it depends on the availability and cost. So not all healthcare facilities, be it primary, secondary, tertiary, quaternary in Malaysia, has the same access to the same treatment. And if you go by individual, always go by the preferred medication. And of course, the phenotype of the patient need to be considered. So we need to decide on that. You also want the patient to get involved on decision of their treatment and get the patient views on what are their goals, their belief, and their concern about asthma. Because this can actually, we learn about our patient's behavior so that we can actually reduce the probability of them not being non-adhere to treatment in future. And some practical issues, sometimes what kind or what type of inhaler would be suitable for them, depending on their suitability, especially on the inhalation efforts. So when you want to choose the inhaler device, so number one, not just the device, but also the compound inside. So the device, depending on the inhalation effort. And the most expensive inhaler is not the one that with high price, but the one that is not used correctly. So always choose the correct inhaler uh, tailored to your patient ability and patient preferences. But somehow in government, you can't really so much depending on patient preferences because of limited quota. But in private, you can actually get the patient, discuss the patient to choose which one they preferred. And of course, we suggest to them which one is the best. So the common inhaler errors is something like considered something like some people, this is something, oh, this is very small thing, but it is not, because this can actually lead to a asthma exacerbation. So insufficient inhalation and not sealing lips around inhalers. So always check the patient's inhaler technique whenever after you start the treatment and during the follow-up following that. And patients sometimes may not be inhaling at all. So maybe they just press the inhaler, just like the one that in the video with a House MD, if you anyone actually ever watched that drama. So she actually pressed as if like she's using the perfume, so not inhaling at all, but she used the inhaler. Okay. So among all the devices, so they have studied. So one of the inhaler that perhaps friendlier to our patients, this is one of the considered dry powder inhaler, but we call it as easy haler. So why is it easy haler? So if you have a MDI, metered dose inhaler versus dry powder inhaler, so the way how you inhale is different. The effort is deep and fast and deep inhalation for a dry powder inhaler. So you need a very high peak inhalation flow rate to inhale the dry powder. However, for metered dose inhaler should be slow and steady. You can't do far deep and quick because it's a miss, and if you do that, then all the mist will go straight to the throat. So all these need to be trained, and of course you can check the inhalation effort with the incheck dial. And usually, if let's say the hospital has RM Tech, the RM Tech pharmacist can help you to see which device that's suitable for that patient. So for easy inhaler, although it's a dry powder inhaler, it does not actually require very high peak inspiratory flow rate. So with anyone with a peak inspiratory flow rate of 30 liter per minute, it should be sufficient to get the drug delivery to the lung using the easy inhaler device. And less error using easy inhaler because not much of instruction. And basically the critical error technique definitely associated with poorly asthma control. And patient can actually achieve a sufficient peak inspiratory flow rate among all the age, regardless age and disease severity. So it doesn't matter whether it's severe or mild. So easy inhaler, the name is easy, so it's quite easy to actually use because it just actually generate about peak inspiratory rate of 30 liter per minute. So you worried about the distribution because a low inhalation flow. So when they studied with the inhalation flow of that low, the distribution, the delivered dose is quite even in the lung. So shouldn't be worried because this is how the device has been engineered to. So you just need a quite a low inhalation flows to actually deliver the drug to the lung. And it can achieve the optimal dose easily because it has a high turbulent airflow as compared to other dry powder inhaler devices such as Tibrohaler or Accuhaler. So we move on to the third phenotype, which is non-allergy asthma. So 40-year-old man, history of childhood asthma. He smoked last time and now changed to vape. So if you look at the spirometry demonstrated obstruction, no reversibility. And what cigarette smokes and the vape actually does to the airway, it actually increases the airway resistance and edema. And actually, it will reduce the response to inhaled corticosteroids. So in other words, if let's say your patient, an asthmatic, still continue to smoke or they start to vape, so even though a good treatment, either you start with the track 1, track 2, the inhaled corticosteroid will not actually work so well. So you need to actually emphasize over and over again for them to actually stop smoking. So let's say the patient has quite a significant history of smoking, so maybe 20 pack over years. So you are query whether are you be dealing with a COPD or asthma. So there is an entity of asthma plus COPD. Last time it used to be called ECOS, but now they put as a asthma plus COPD. How do you treat if let's say this patient has both asthma and COPD? Always treat as per asthma. So always start with the ICS component containing treatment plus long-acting bronchodilator later. So if let's say the symptom more towards COPD means that they do not have intermittent or episodic, the dyspnea persistent most of the days, then you are going to treat the patient as per COPD. So this is always can be obtained from your history alone and also complemented with your lung function as well. But careful, sometimes the lung function can demonstrate persistent expiratory flow. So we do have a patient with asthma with persistent airflow limitation. Oh, this is sounds like COPD, but they are not COPDs. They have asthmatic for many years, long-standing, frequent exacerbation, suboptimal treatment, and they actually get admitted even to high dependency unit. Perhaps this patient not intubated, but not she's not productive, unable to go to work because very symptomatic, and she gained weight because of frequent OCS bursts. So how do you deal with this patient? So there are actually entity asthmatic patient has a fixed airflow obstruction. So this is due to the long-standing disease because of frequent exacerbation, not treated with anti-inflammatory very well. That's why they emphasize now track 1 or track 2 both has ICS contained treatment. Even though they have symptom that they might just need a bronchodilator, you still need to combine with the inhaled corticosteroid to treat this airway inflammation. So whether this patient has difficult to treat or severe asthma. So severe asthma is another small entity of poorly controlled asthma. So it's about 3.7% that the patient has severe asthma. So why is it difficult asthma? Why there is a severe asthma? Does it sound the same? Well, both are poorly controlled asthma, but severe asthma is something that you cannot find any contributing factor. Means that they adhere to treatment, their technique is good, their triggering factors actually well controlled, their comorbidities are treated well. Whereas for difficult asthma, there are modifiable triggering contributing factors that you can actually optimize. Then once you optimize, this difficult asthma can go to the good control asthma. So these are the definition of based on the GINA and also the international guideline on how you actually considered a severe asthma. It's only considered asthma is controlled despite maximal optimized high dose ICS, which require one to remain uncontrolled after contributing factors are addressed. So always check inhaler technique, adherence, comorbidities has been treated, and also the optimized treatment according to the stepwise treatment. So this systemic corticosteroid has a lot of side effects. The diabetes mellitus, they can get cataracts. All these actually can be contributed from the accumulated dose of inhaled corticosteroid and also oral corticosteroid particularly. So you need to consider whether your patient need to be further phenotyped, whether this patient meant for biologic treatment or not. So there are a few biologic treatment are available, which I'm not going to go into detail. So according to the phenotype, whether they are pro-eosinophilic or more to allergic phenotype, or they have mixed, so we can consider whether they are eligible for anti-IgE, anti-IL-5 or anti-IL-4 receptor and also anti-TSLP. This is the new kid on the block that can actually block upstream. And that this cater for patient that has 50-50. So a bit eosinophilic and a bit allergic. And sometimes they can also be also with a neutrophilic predominant asthma. So once the patient already on targeted to therapy, so it's not again not CTS, so you still have to review the response. So whether you can achieve clinical remission, and sometimes it's a pharmacological remission, means that they are out from the biological treatment, and perhaps one day the patient should be on inhaler technique once we already resuscitated the airway inflammation with a biologic treatment. We also have a cough variant asthma as one of the phenotype asthma. They come with just a cough, early morning and nighttime, still episodic, but no wheezing. So past medical history, maybe they have childhood asthma, they have allergic rhinitis and GERD. And how do you actually treat this? Go back to the same thing. So why they only have cough? Because the airway inflamed, but maybe there's no hypersecretion mucus. So the airway is not blocked. So if they have, once they have the chest tightness, you know, the smooth matter is actually getting thicker and a lot of secretion that actually going to reduce the caliber of the airway. And once they have the wheeze, means that there is a lot of hypersecretion and smooth muscle hyperplasia. And you can go same thing for cough variant asthma, whether you go for track 1 or track 2 and just treat as per asthma also. Last but not least is asthma with obesity. So we are champion for obese in Malaysia. So 45 male diagnosed with asthma, obesity, BMI of 40. So he may have symptoms that may suggest of obstructive sleep apnea. Recurrent admission, the moment that they get this admission, then you give them corticosteroid, the weight is going to increase over, then the asthma control still not better because the weight increase. So how do we actually tackle this patient? So what obesity can do to the lung? So it can cause steroid resistance, it can cause more inflammation. The asthma, the obesity can reduce the FRC and actually and also ERV. This is the residual volume and also the functional residual capacity because of the abdominal adiposity. And increased leptin in airways also can reduce the adiponectin. And this is highly related to TH1 rather than TH2. No, so this is more to type 1 asthma rather than type 2. So more to neutrophilic. But they are also associated with small airway dysfunction also in obese patient. So you might actually need to consider a compound that has extra fine particle like beclomethasone, or you may want to actually phenotype the patient. Maybe obese patient has some more type 2 inflammation. But if let's say they do not have type 2, they only pure type 1, so you might want to consider. So this is a study done in the UK. So they look at the patient obese with a high risk asthma. So the impact of the glucolide peptide receptor agonist. So don't just think that this GLP-1 receptor agonist is just meant for cardiovascular outcome and kidney outcome, but also for asthma as well. So it found that it can improve composite measures of asthma control, especially for patients that on this and for weight loss, it can actually benefit more on treating the obesity as a comorbidities and translate to a better asthma control. So I come to the last slide. So simple rules, always check your patient whether they smoke or not. Inhaler technique suitability. Always monitor your patient and check the status of their asthma control. Either you use ACT or GINA questionnaire. Check their pharmacotherapy. Is it suboptimal or you need to actually consider to step down the treatment. Check their lifestyle. Always educate your patient and always support your patients. So as a take-home message, it's important to actually recognize asthma early because that will determine their initial treatment and actually will determine their future outcome. Always assess severity, control, and risk. Do not just ask, are you okay or not okay? That is not good enough. Avoid delay or suboptimal treatment. Always optimize treatment according to their severity and their asthma control. Tailor therapy according to the patient phenotype. Do not apply CTS. Okay, continue the same treatment. And this phenotype, the control is to get the lung dose of that patient. And always follow the assess, adjust, and review cycle. Thank you very much. Also, these are the two guidelines that can be referred to. So one is GINA 2025. And if you want a local flavor, this is our CPG management of asthma in adults just launched last month. Thank you so much.
Thank you so much, Dr. Shakirin, for your comprehensive and insightful presentation. Particularly, the emphasize on the individualized asthma action plans and the update on the latest GINA guideline. Once more, I would like to thank the participants. We are truly encouraged by the overwhelming response. More than 400 participants, to be exact 450, tuning for tonight's session. So if you have any question, you can write in the Q&A box and we will address only after our second talk. So let's move to our second presentation. Now, having explored asthma in the adult population, let us shift our focus to a group that is often more vulnerable and in fact makes up a significant proportion of asthma patients, children. In Malaysia and globally, pediatric asthma remains a major cause of emergency visits. Early diagnosis and effective management are crucial to ensuring long-term respiratory health in our pediatric population. With that, it is my